Bismillah ar-Rahman ar-Rahim. Thank you actually to the organizing team for the invitation. This is a very elegant meeting, and I think it touched base in a very important subject that we really need to have more awareness and more implementation to what has been the evidence shown to treat our patients. The Saudi guidelines for dyslipidemia management was actually one of the projects that has been done to emphasize on the importance of dyslipidemia and how we really need to give all our physicians the tool that will help them, give them the confidence and the trust to treat the patient according to the need. So I would like to also take this opportunity to thank all the experts who really joined in developing these guidelines, who devoted their time, collected their knowledge, and whatever in the literature that can support putting these documents together in the best shape that we have it published in. Should I go forward? Okay, so as we all know, the main objective of developing the guidelines was to have a nationwide evidence-based policy and guidelines to implement a unified approach for the management of dyslipidemia in our country. The Saudi clinical practice guidelines will provide the recommendation applicable to the Saudi patient with or at risk of developing cardiovascular diseases. So we all know the burden of the cardiovascular disease. We know that it is underdiagnosed, and more than 65% of the Saudis are having dyslipidemia, which is either not on treatment, being not diagnosed, or they are not aware of having that disease. We also know that the management of dyslipidemia, as we saw in the evidence with the previous talks, that it is really undertreated. And emphasizing on the proper escalation of therapy to treat this group of patients should also be recommended. So what we really use in the guideline, we use the methodology depending on a class of recommendation, starting with class 1, depend on the evidence and the general agreement that we have, class 2A, and then to class 3, class 2B, and then to class 3 when the evidence do not support the recommendation. And this was adapted from most of the international guidelines recommendation, and particularly the European guidelines. And the reason of the similarity of having a lot of risk factor parameters as well as the population and the culture that we have here in Saudi Arabia. So the European Society of Cardiology guidelines recommendation and the categorization, the target, and the cutoff were the main guide while we develop our Saudi guidelines. It is strongly believed that the tight control imposed by the European Society is the most appropriate to our population, particularly with the emphasis of premature atherosclerotic vascular disease in our Saudi population. And it's very important to say that all the experts who were involved in developing these guidelines declare no real or potential source of conflict of interest to developing these guidelines. Now, when I look at the series of talk that we have since the beginning of the conference, it's very easy now to present the guidelines because I think knowing all what has been presented as an evidence from the literature was actually imposed in the guidelines. So I would like to present it as a key messages, which is 10 recommendations, summarize what we really want these guidelines to be understood and implement in the clinical practice. I will also touch base on the gap in care, which was highlighted by Dr. Shukri in his presentation. And that can cover some of the questions when we ask why our patients are not in a good control, why we are not seeing the implementation of what is recommended in our follow-up. So let's start with message 1. I think this is very important now, seeing a lot of questions was raised to Prof. Awan and highlighted by Dr. Shukri as well, the premature atherosclerotic disease. When we screen our patient, what do we use as a risk score calculator, and what age or cutoff age that we really have to highlight for our Saudi population, knowing that the evidence of acute coronary syndrome happen in a younger population. So if you see in the guidelines, our recommendation was very clear to recommend the score system, and I think Dr. Shukri was very generously explaining the system and the parameter involved in it. And we were also very clear in in the age cut of developing screening parameters for our population. So patient above the age of 40 is a class 1 recommendation. Patient above the age of 20, which is much younger, giving the usefulness of doing the screening, we gave it a class 2A recommendation. And that was particular to the Saudi population. Now, the development of a new risk calculator, which will be optimized for the Saudi population, I'm glad to say that it is actually in process, and very soon we're going to see the light of this particularly implemented cardiovascular risk for the Saudi population. Now, this is a very important graph. I would recommend most of our physicians to have it in their clinics, not necessarily a lipid clinic, but any clinic that deal with this group of patients. And as you can see, it really summarizes how we categorize the risk score, starting from low to extremely high risk, which was added in our guidelines, emphasizing on the patient who is having a recurrent event despite being on therapy. And it also adds the target level, not only to the LDL, as well as to the non-HDL and the ApoB, giving the importance of investigating these parameters in certain group of patients, as we heard from Prof. Awan lecture, particularly the metabolic syndrome and the diabetic patient. So I really think that this can guide any physician very easily to look what target we need to achieve and how I can categorize my patient risk. So that's for the risk assessment or risk score categorization, which is the key message 1 in the guidelines. Moving to the key message 2, which I think Dr. Awan gave us a very thorough review on how to do the lipid analysis. And here again, I want to emphasize how the guidelines really highlighted the importance of doing the non-fasting versus the fasting. I see the question and answer that we are receiving. Still, we have a lot of questions about why we have to do a non-fasting and what is the period of hours that is recommended for fasting. So let's agree on one thing. To screen patient, non-fasting lipid analysis is recommended. And it showed that it will not really bias your cholesterol level or how you will really define it. Now, once you have an abnormal screening result, you have to do the fasting, and that's how we'll make easy for patient to really have their lipid analysis. And if you look at our level of recommendation, we give the fasting lipid profile class 1 recommendation because it still stands in the evidence that it needs to be done in any patient who have an abnormal screening parameter. Now, what is the role of the non-HDL or the ApoB? We know that we can measure them directly and accurately, and they can give a better prediction of the risk compared to the LDL. However, it has to be available in your institute, so you can be able to order them. And they are an alternative parameter, particularly for screening, confirming diagnosis, and managing selective group of patients. And again, here we highlight the patient with metabolic syndrome, the patient with diabetes. And I can stand here and mention a small example. I saw a patient who was admitted in our center last week, third event of MI, LDL of 0.8, and the patient in a combination therapy of statin and ezetimibe. The discussion was, should we add the PCSK9, given that the LDL is less than 1, which is the extreme high-risk cutoff level, or should we look for something else? And I think this is the group of patients where we have to investigate more. And here where non-HDL and ApoB will really guide us in the therapy. We did recommend to add the eviculumab to his regimen of therapy to be aggressive in all parameters to treat this recurrent acute coronary syndrome events. So that's the message number 2 in our recommendation guidelines regarding the lipid analysis. We have a very thorough tables explaining the goal of the disease and each different parameter in the lipid analysis, which I recommend everyone to have it as a reference. Now I will move to message 3, which is really looking at the risk enhancer and the risk modifiers. And I believe most of the cardiologists as well as endocrinologists, they do look at that when we are facing a patient with dyslipidemia, highlighting the metabolic syndrome risk, patient with chronic kidney disease, patient with diabetes, and so on. And I think this is very important to be highlighted, to recognize this patient and follow the recommendation according to the class that was collected based on the available evidence-based literatures as well as information. So same thing in message number 4, which is the risk modifier. And maybe a small message here has been added, which is relating to the coronary artery calcium scoring. And this is an additional tool that will help you to identify the high risk from the very high risk, because we did say that acute coronary syndrome as well as coronary artery disease, either clinically or through imaging. So this is, again, a class 2A recommendation that can be used as a recommendation in our particular population. Now I want to move to a very important message regarding a selective clinical setting where we really have to be more meticulous in managing this group of patients. And here I'm talking about patient with acute coronary syndrome, patient who has diabetes, patient who have chronic kidney disease. And these are the category of patients where you really have to always consider combination therapy. Now, acute coronary event by itself can mandate you to start a triple therapy if the LDL is above the cutoff value that we are looking for. I know most of the physicians will be reluctant to jump, adding more than medication at once, but given the seriousness of the disease and the class of the recommendation reviewing the effect and the outcome of the therapy, patient who is not responding to statin or ezetimibe should have the PCSK9 added to their therapy and looking to reach the cutoff value of the target LDL. Now, the very extreme risk are the population with recurrent acute event are the one to start the triple therapy, and I would really encourage most of the cardiologists to adopt what it has been approved in the guidelines that it will be useful to manage our patient. Now, having no enough local data, and maybe our registry soon will help us in that, this class of recommendation, I'm quite sure in the updated version of the guidelines will move to class 1 recommendation, giving the benefit of the therapy. Now, one line here I want to add regarding very specific group, which is the pregnant ladies and women who are lactating. And I saw some questions concerning on that. Now, up to date, we know that the medication we are using is not safe during pregnancy, and we are mainly recommending on lifestyle modification, close follow-up for these patients, and trying to help them with their diet control, exercise, and watching their meals. So I think up to date, we don't have a safe medication to be used in this particular group of patients who are the pregnant ladies or the lactating women. I will move to message 6, which is for the particular group of the familial hypercholesterolemia, and establishing a national program and policy, i.e. the National Saudi FH Registry, supporting the genetic analysis, setting up a very specialized lipid clinic, and raising the physician awareness is recommended for early detection of FH in Saudi Arabia. And I think our experts here presented enough data to support what came in the guidelines and has been placed as a class 1 recommendation. Now, the guidelines also included some algorithms that can help the physician guide them easily and be a very accessible tool wherever they need it. And here will come starting the pharmacological therapy approach, either statin or the other medication. And I think one of the things that give a fear of using statin either to physician who's ordering them or to the patient to be compliant is the known side effect or what has been already published as a side effect for using statin, which either the muscle injury or the liver injury. So here we provided in our guidelines a very simple approach how we deal with this group of patients. There was a question as well in the Q&A where we have to stop statin, what level of ALT that we can accept, and what level we have to investigate and stop the therapy. Same thing about the CK level. So I think this algorithm can help them and will guide the monitor safety in this group of patients with this medication. Now, the treatment goal for LDL in Saudi Arabia using the most important currently approved by Saudi FDA medication stand by itself as a key message that's important for physicians to adapt. And here I want to highlight more on the importance of adding the PCSK9 monoclonal antibody or even the messenger RNA medication that will definitely help in reaching the cutoff. This is for primary prevention as well as for secondary prevention, and it carries a very important class of recommendation in our specific group, Saudi population. The key number 9 is basically the approach that we can utilize in our clinical setting, either inpatient or outpatient, patient who is admitted with atherosclerotic events, and how we can escalate the therapy. And again, we tried to make it in a very simple algorithm, which can be as a reference, handy tool for the physician to use. Strengthening the treatment goal is important to ensure that treatment of the highest risk patient achieving the largest LDL reduction possible by setting both a minimum percentage of LDL reduction as well as an absolute LDL treatment. And this is particularly for very high risk and extreme high risk group of patients. Now, the last message here is basically the gap in care that we really need to refocus again, knowing now that we have a document that supports the therapy that we have to use in our patient. What is the risk stratification that we can use, particularly for the Saudi population, and why there are still gaps in our care. So I think this is very important messaging, looking at the standard policy, which is now available, to really work on the rest of the available tools that can help and has been recommended in the review. So it's very appropriate to manage our patient in the Saudi population by adopting a multidisciplinary approach involve the patient, the physician, the medical societies, and even the governmental agencies. Now, I don't think I have really to highlight what is really the health technology assessment trend on dyslipidemia management, which was a separate chapter in our guidelines after we heard Professor Jideh and his extensive talk about the value-based healthcare strategies that has been taken. It is, I think, now one of the most recommended cost-effectiveness implementation that we have to use. And I'm really glad to hear that when Professor Jideh mentioned the step approach to develop the strategy, number one was developing the Saudi guidelines. So achieving part of these steps, I think we are really reaching there. And very soon we're going to see the effect of the registries on what access to healthcare system has been with the transformation and the cost-effectiveness pharmacotherapy has achieved. Now, the final document is ready for the decision maker. And the decision maker here, not only the healthcare governance, it's all of the physicians. The physicians are decision makers for their patients. Choose the medication appropriate as per the recommendation to reach the target that should your patient achieve. It is updated. It is covering all the available up-to-date literature for our national and international data. These guidelines were completed in October 2022. So up to that date, there were no single literature by all the experts who joined in developing the guidelines, did not leave any single literature without being included. I'm sure the data and the development of an updates is ongoing, and there will be a need to update the knowledge very soon. However, it is the most updated document that you can use. So I think this is a very strong indication that we have now a national document, give us a clinical pathway, highlighting on the gap, important pharmacotherapy, and how we risk stratify our patients. It is available in the Saudi Health Council website and has been published in the hard view and can be easily used as a reference. And we are happy to answer any question. Thank you.